Welcome to another lesson, everyone. Now I will discuss about apnea. Apnea is a prolonged cessation of respiration and usually defined as cessation of breathing for a period of greater than or equal to 20 seconds or a period less than 20 seconds that is associated with a change in tone, pallor, cyanosis, and bradycardia. Periodic breathing pattern is characterized by brief episodes of respiratory pauses lasting 5 to 10 seconds, and this is followed by a burst of rapid respiration at a rate of 50 to 60 breaths per minute for 10 to 50 seconds. In periodic breathing, unlike that of apnea, brief interruptions in respiration are not associated with change in color or heart rate, and it is a normal characteristic of neonatal respiration and has no prognostic significance. There are different types of apnea. Based on the absence of respiratory effort or airflow, apnea can be obstructive, central, or mixed. Obstructive apnea is caused by pharyngeal instability, neck flexion, and others. And it is characterized by absence of airflow but persistent chest wall motion. Pharyngeal collapse might follow the negative airway pressure generated during inspiration, or it might result from incoordination of the tongue and other upper airway muscles involved in maintaining airway patency. The second is central apnea. Central apnea is caused by decreased CNS stimuli to respiratory muscles, resulting in both airflow and chest wall motion being absent. Gestational age is the most important determinant of respiratory control, with the frequency of central apnea being inversely related to gestational age. The maturity of the brainstem respiratory centers is manifested by an attenuated response to carbon dioxide and a paradoxical response to hypoxia that results in central apnea rather than hyperventilation. The third one is mixed apnea. This is most often observed in apnea of prematurity, with obstructive apnea preceding central apnea. Short episodes of apnea are usually central, whereas prolonged ones are often mixed. Apnea depends on the sleep state, and its frequency increases during active or during rapid eye movement sleep. Apnea is usually observed in preterm infants as a result of immature respiratory control or an associated illness. Apnea in term infantis is uncommon, often associated with serious pathology and demands prompt diagnostic evaluation if it occurs in term babies. Apnea accompanies many primary diseases that affect neonates by direct deprivation of CNS control of respiration, such as hypoglycemia, meningitis, drugs, intracranial hemorrhage, seizure, or by disturbances in oxygen delivery, such as shock, sepsis, anemia, or by ventilation defects, such as obstruction of the airway, pneumonia, muscle weakness, and the like. When we see apnea of prematurity results from immature respiratory control, most frequently occurs in infants less than 34 weeks of gestational age, and it occurs in the absence of identifiable predisposing diseases, except prematurity. Apnea of prematurity is almost universal in infants born at less than 28 weeks of gestational age, and the incidence rapidly decreases from 85% of infants in less than 13 weeks to 20% of infants in less than 34 weeks of gestational age. The onset of apnea of prematurity can be during the initial days to weeks of age, but it is often delayed if there is respiratory distress syndrome or other causes of respiratory distress. In premature infants without respiratory disease, apneic episodes can occur throughout the first 7 postnatal days or during the first weeks of life with equal frequency. Bradycardia follows the apnea by 1 to 2 seconds in greater than 95% of cases of apnea of prematurity, and it is most often sinus, but on occasion it can be nodal. Vagal responses and rarely heart blocks are cause of bradycardia without apnea. Apnea that occurs in the absence of other clinical signs of illness in the first 2 weeks in preterm infancy is likely apnea of prematurity. Therefore, additional evaluation for other etiologies is often unneeded, and we should have to keep our diagnosis as apnea of prematurity if it occurs in the premature babies during the first 2 weeks of life. However, the onset of apnea in a previously well-preterm neonates after the second week of life or in term infantis at any time is a critical event that might be associated with serious underlying pathology. So in this case, we should have to search for the underlying causes. If apnea occurs in preterm neonates after 2 weeks of age, and if apnea occurs in term infantis at any time. When we see treatments of apnea of prematurity, gentle tactile stimulation or provision of flow and or supplemental oxygen by nasal cannula is often adequate therapy for mild and intermittent episodes. Nasal CPAP or heated humidified high flow nasal cannula at 1 to 4 liters per minute are appropriate therapies for mixed or obstructive apnea because they splint the upper airway to prevent airway obstruction. Both are used widely, but nasal continuous positive airway pressure or nasal CPAP might be preferred in extremely preterm infantis because of its proven efficacy and safety. Recurrent or persistent apnea of prematurity is effectively treated with methylxanthines. Methylxanthines increase central respiratory drive by lowering the threshold of response to hypercapnia as well as enhancing contractility of the diaphragm and preventing diaphragmatic fatigue. Caffeine and theophylline are similarly effective as methylxanthines, but caffeine is preferred because of its longer half-life and lower potential for side effects such as tachycardia and feeding intolerance, which is caused by methylxanthines. Caffeine therapy can be safely administered orally or intravenously with initial loading dose of 20 mg per kg, followed 24 hours later by once daily maintenance dose of 5 to 10 mg per kg. Monitoring is primarily through observation of vital signs such as pulse rate and based on clinical response. Initiation of caffeine in the first 3 days of age in extremely preterm infantis less than 28 weeks of gestational age as a prophylaxis might improve outcomes because apnea is common almost universal in less than 28 weeks of gestational age. However, it is reasonable to delay caffeine therapy until apnea occurs. Caffeine therapy is usually continued until an infant is free of clinical significant apnea or bradycardia for 5 to 7 days without positive pressure respiratory support or at 34 weeks post-menstrual age. A preterm infant who is having apnea of prematurity, and if there is significant anemia, transfusion of packed red blood cells increases blood oxygen carrying capacity and improves tissue oxygenation, and it's associated with a short-term reduction in apnea. In preterm infantis, medications that inhibit gastric acid production have potentially harmful side effects because it increases the incidence of sepsis, necrotizing enterocolitis, and it increases the risk of neonatal death, and it might actually increase the incidence of apnea and bradycardia. Therefore, the routine use of medications that inhibit gastric acid synthesis or that prompt gastrointestinal motility to reduce the frequency of apnea in preterm infants should be discouraged. Regarding prognosis, in 92% of infants by 37 weeks post-menstrual age and in 98% of infants by 14 weeks post-menstrual age, apnea of prematurity resolves spontaneously. However, infants born well before 28 weeks gestational age might experience apnea and bradycardia events until 44 weeks post-menstrual age. However, it is recommended that an infant demonstrate an event-free period of 5 to 7 days before hospital discharge. In the absence of significant events during hospital stay, home monitoring can be safely discontinued at 44 weeks post-menstrual age after hospital discharge. This is all about regarding apnea and also apnea of prematurity. Thank you for watching. Have a nice time.